Our third lecture will be on redefining survival expectations in non-small cell lung cancer. May we call on Dr. Guia Ladera, the chairperson for this session. Dr. Ladera is a fellow of the Philippine College of Physicians, of the Philippine College of Chest Physicians, and the Philippine Society of Oncology. She completed her training on both subspecialties from the Jose Reyes Memorial Medical Center. Her field of interest are researches focusing on solid tumors and lung cancer. At present, she is the Department Manager 3, acting as the officer in charge of the Thoracic Oncology Department of the Lung Center of the Philippines in Quezon City. She is also the chairman of the Council on Lung Malignancy at the Philippine College of Chest Physicians. May I call on Dr. Guia Ladera to introduce the next lecturer?
Good evening, everybody. I'm Dr. Guia Ladera. I am from the Lung Center of the Philippines and will be the chairman for this evening's lecture. So again, good evening, ladies and gentlemen, our friends and colleagues. I'd like to introduce our guest speaker for this evening, and his name is Dr. Ang Soo Fan. He is here with us tonight to discuss the topic on immuno-oncology in untested and PD-L1 negative non-small cell lung cancer, an evolving landscape. He is a consultant medical oncologist from the National Cancer Center, Singapore, and he is also a visiting consultant medical oncologist at the Penang Adventist Hospital. He has a keen interest in colorectal cancer, liver, nasopharyngeal, and breast cancers. He is actively involved with multiple investigator-initiated and pharmaclinical trials. He is also a reviewer of many peer-reviewed journals. He has presented several posters in the international conferences, including the annual meeting of the ASCO and ESMO, and is also a contributor to publication in peer-reviewed journals. He is also a member of many professional organizations that includes the American Society of Clinical Oncology and the Singapore Society of Oncology. He is also a recipient of multiple awards in recognition of his exemplary services to patients. That includes the Klang General Hospital Excellence Service Award and the Singapore Health Quality Service Award. So friends, colleagues, ladies and gentlemen, let's all welcome Dr. Ang Soo Fan.
I would like to thank Asian Oncology Society for having me here today. Today we are going to discuss the role of immunotherapy in untested PD-L1 low as well as PD-L1 negative advanced non-small cell lung cancer. This is my disclaimer. When we see a patient with advanced non-small cell lung cancer with PD-L1 more than 50% without driver mutation, this is the standard of care, which is immunotherapy alone or combination of immunotherapy with chemotherapy. Checkpoint inhibitor must be part of an essential treatment because checkpoint inhibitor improve all survival outcomes as well as long-term survival. There is a significant number of patients who can live more than 5 years, and this is something unprecedented. So this is because we have seen the data from Keynote 024, and in this study they included patients with stage 4 non-small cell lung cancer, including non-small cell as well as squamous cell carcinoma with PD-L1 more than 50%. In this study, we compare pembrolizumab versus chemotherapy. And what we noticed in this study is that the response rate is much higher than chemotherapy alone, which was 45% versus 28%. After median follow-up of almost 5 years, we can see the median survival was 26 months versus 13 months. And what is more important is this long-term survival, which is seen is about 32% of patients as compared to 16% in the chemotherapy arm. So we also noticed the similar findings in Empower Lungs 1 study, which was presented recently in the ESMO. In this study, sapilimab once again showed a better outcome compared to chemotherapy with median survival of 22 months versus 14 months, and those with more than 50% of PD-L1, we also can see there is a long-term survival benefit noticed in the Sepilimumab arm. Okay. Keynote-001 is one of the earliest phase 1 study on pembrolizumab in treatment of non-small cell lung cancer. Right? So what we can see in this study is that, right, for patients who with TPS more than 50%, we see almost 30% of long-term survival in which the patient survived more than 16 months. Even in those who are previously treated, for those patients with TPS score more than 50%, we do notice 25% of these patients live for 5 years. So I'm sure you agree with me now, checkpoint inhibitor must be an essential part of treatment because it improves all survival outcome and it leads to an unprecedented long-term survival outcome in about 30% of patients. What about the role of checkpoint inhibitor in patients with PD-L1 low or negative non-small cell lung cancer? Should all patients receive first-line checkpoint inhibitor regardless of the PD-L1 status? Right. So here we are going to study more trials to help us answer this question. In Keynote 189 study, this study recruited patients with stage 4 non-squamous non-small cell lung cancer regardless of the PD-L1 status, and they randomized patients to receive chemo plus pembro versus chemo alone. Okay. So in these studies, 1/3 of the patient has PD-L1 less than 1%, another 1/3 PD-L1 1 to 49%, and another 1/3 with PD-L1 more than 50%. Right? So what we notice here, response rate is increased in all the PD-L1 subgroups. Right? And the highest response rate was noticed for those patients with PD-L1 more than 50%, 61%, right, versus 22% in the chemotherapy arm. So remember from the Keynote 024, the response rate was 46% with pembro alone. In those with low PD-L1 levels, the response rate was almost 50% compared to 21%. And for those with TPS less than 1%, we do notice the response rate was 32%, which double the one we saw in chemotherapy alone. Yeah. What about the progression-free survival? So, and in these studies, we notice TPS progression-free survival is the highest in those with high PD-L1 status. The median PFS was 11 months versus 5 months, and for those with low PD-L1 status, the PFS was 9 months versus 5 months, and for those with negative PD-L1, the progression-free survival was 6 months versus 5 months, and this is statistically significant. In terms of overall survival, in the intention to treat population, again we notice there's a significant OS benefit, 22 months versus 10 months, right? And this OS benefit again is seen across all PD-L1 levels, right? Of course, the highest OS benefit was seen in those with PD-L1 more than 50%, right? Even with for patients with TPS score less than 1%, we again notice the OS benefit was 17 months versus 10 months, and this is statistically as well as clinically significant. Overall survival is seen across all subgroups, right? Especially for those with brain metastases, where we notice the OS benefit is better if we combine chemotherapy with pembrolizumab as compared to chemotherapy alone. Right. What about the side effects? Right? I think we all agree pembrolizumab as well as other checkpoint inhibitors are very well tolerated treatment. We do not notice a very significant increase in toxicity with pembrolizumab and chemotherapy combination. However, when we start a patient with immunotherapy, we must always tell the patient that there is a risk of immune-mediated toxicity, In fact, this toxicity happened in about 25% of patients. Right? So it is something not rare when we combine all the rare toxicity together. In Keynote 407, this study included patients with squamous cell non-small cell lung cancer, regardless of the PD-L1 status. Again, this study compared pembrolizumab with chemotherapy versus chemotherapy alone. Right? About 26% of patients has PD-L1 of more than 50%, 37% with PD-L1 1 to 49%, and another 34% of patients has PD-L1 less than 1%. So in this study, again we notice the response rate is higher with patients on pembro with chemotherapy, about 58% compared to 38% for those patients with chemotherapy alone. In the overall population, combination immunotherapy with chemotherapy increased the PFS 8 months versus 5 months. Right? So when we look at the PD-L1 subgroup, we notice pembro with chemo increased the PFS in both subgroups. So for patients with PD-L1 more than 1%, right, we notice significant PFS benefit 8 months versus 4 months. For those with PD-L1 less than 1%, we also notice there is also an increment in the PFS benefit. This study also reported PFS2. Right? What is PFS2? PFS2 is defined as time from randomization to objective tumor progression on the next line of treatment or death. Right? PFS2 is important because it allows us to assess the effect of first-line pembro plus chemo on the subsequent therapy. We notice median PFS2 was substantially improved in these studies. Right? Clinical benefit of pembro were maintained after initial progression, and this supports the use of pembro with chemo combo over second-line pembro alone. In terms of overall survival, again, patients on pembro chemo has a significantly improved overall survival of 17 months versus 11 months in the chemo group. We also notice overall survival is improved for those with TPS more than 1% as well as those with TPS less than 1%. In the Empower 150 studies, this study includes non-squamous non-small cell lung cancer regardless of the PD-L1 status. So in this study, it compared atezo bevacizumab plus chemotherapy versus atezo with chemotherapy versus bev with chemotherapy. And again, this study showed there is overall survival benefit in atezo bev with chemotherapy arms. Right? And this benefit is noticed for those with PD-L1 positive patient as well as PD-L1 negative patients. There are not many phase 3 immunotherapy studies that only focus on patients with PD-L1 less than 1%. Right? However, we have a pool analysis of Keynote 021, Keynote 189, as well as Keynote 407. In this study, we only focus on patients with PD-L1 less than 1%. Right? We have discussed about Keynote 189 and Keynote 407 before. And in Keynote 021, this is a study that includes immunotherapy with chemotherapy regardless of the PD-L1 status in only non-squamous lung cancer. There were 428 patients with PD-L1 less than 1% included in these studies. Right? The baseline characteristics were almost balanced in these two groups of patients, except that we have more squamous histology patients in the chemotherapy arm, as well as slightly more patients with liver metastasis. This study showed that the response rate is much higher with pembro chemotherapy combination 47% versus 28% in the chemotherapy arm. Again, this actually tells us combining pembro with chemotherapy is beneficial even in a patient with PD-L1 less than 1%. What about the progression-free survival? Again, we notice a slight improvement in progression-free survival with a hazard ratio of 0.67. However, overall survival increment is quite substantial. It's 19 months versus 11 months with a hazard ratio of 0.56. Again, overall survival is improved in most of the subgroup, whether this is squamous or non-squamous. And again, patient with brain metastasis has a better outcome if we combine pembrolizumab with chemotherapy. When we start patient on immunotherapy, we must always remember to tell the patient that immunotherapy could potentially lead to fatal toxicity. However, this toxicity is something that is very preventable if we can detect the toxicity early and treat it early. What else can we do to improve the outcome for patients with non-small cell lung cancer with PD-L1 less than 1%? Can we combine anti-PD-1 with anti-CTLA-4? Yes, this is answered in this study, Checkmate 227. Yes, Checkmate 227 has tried to answer this question. This study recruited patients with squamous as well as non-squamous lung cancer and is divided into two parts. Part 1A includes those patients with PD-L1 more than 1%, and Part 1B included patients with PD-L1 less than 1%. Right? In the Part 1A studies, there are three arms: Nivo-EP, chemotherapy alone, and Nivo alone. In the Part 1B, the nivolumab is combined with chemotherapy. Interestingly, we noticed Nivo-EP was the winner because it has the highest PFS as well as OS benefit. For those patients with PD-L1 less than 1%, again, we notice Nivo plus EP has highest benefit in terms of overall survival than chemotherapy or Nivo plus chemotherapy. In terms of response rate, we again notice combination of EP, Nivo has a better response rate compared to Nivo and chemotherapy alone for patients with PD-L1 less than 1%. Right? And we also notice median duration of response is much higher in the Nivo-EP arm as compared to Nivo chemotherapy arm. Of course, combination Nivo-EP has a higher toxicity. In the latest NCCN guideline, Nivo and EP was included as part of a treatment guideline for those patients with PD-L1 less than 1% with good performance status. What about combining two IO with chemotherapy? Yes, Checkmate 9LA study tried to answer this question. In this study, they include patients with squamous and non-squamous lung cancer with PD-L1 less than 1% versus PD-L1 more than 1%. And in this study, we combine Nivo-EP with chemotherapy for 2 cycles and versus chemotherapy alone for 4 cycles. And this study actually shows if you combine Nivo-EP with chemotherapy, it actually has a better outcome in terms of overall survival compared to chemotherapy alone. Right. And this overall survival is again seen across all PD-L1 levels, whether this is less than 1%, 1 to 49%, or more than 50%. In NCCN guideline this year, Nivo-EP with chemotherapy is included as part of the treatment guideline for PD-L1 more than 1% in patients with good performance status. What about tumor mutational burden? Unfortunately, in the Keynote 189 study, tumor mutational burden is not a predictive marker for pembrolizumab's efficacy. in the keynote 407 as well, tumor mutational burden did not predict the outcome with chemoimmunotherapy. In the Checkmate 227 studies, tumor mutational burden again is not a good predictive marker for the outcome. In conclusion, patients with advanced non-small cell lung cancer who express PD-L1 more than 1%, IO should be incorporated into first-line treatment. For patients with PD-L1 more than 50%, single-agent immunotherapy or immunotherapy chemotherapy combination should be considered. In patients with PD-L1 less than 50%, we always need a combination. Immunotherapy improves all survival outcomes, and remember, there are significant number of patients have long-term survival with durable response of more than 5 years. In patients with advanced non-small cell lung cancer with PD-L1 less than 1%, IO chemo combination demonstrated a clinically meaningful improvement in all treatment outcomes too. IO chemo has a manageable safety profile. However, all patients must be properly counseled on the immune-mediated toxicity and warned against the rare fatal side effect. Double IO or double IO with chemotherapy combination may be considered for advanced non-small cell lung cancer with PD-L1 less than 1%, but this comes at a higher toxicity rates. Thank you very much for your attention.